Should we take our seats? All our panelists in place. All right, everybody, I have got the great honor and privilege to chair this panel discussion. What we're going to do is we're going to have some questions to our panelists, and then we're going to open after each question to the floor. Now, those with a cunning eyesight will strategically see a little row of gifts, 6 gifts for the first question, people who ask questions or participate. That's to encourage participation. For the people after the first 6, we've got a little bit of a sugar load which we can distribute. So, without further ado, I'm going to direct the first question at Frederick. So, Frederick, if cardiovascular risk is elevated in post-TB, what measures should we be considering to manage patients, or what interventions should we be studying?
Okay, so we have been discussing 2 years ago already, what are we going to do with patients, what is the minimum assessment that we need to do with patients with post-TB lung disease. Now we are talking about what do we need to do with patients who have post-TB in terms of their cardiovascular risk. And I just want to, we have been always talking about cardiovascular disease here, but we need to split cardiovascular disease up into coronary artery disease and other cardiovascular diseases. And we talked about pulmonary hypertension, but we ought to need to speak about cardiomyopathy. And we've looked at the echo results. A lot of them have preserved ejection fraction. We know that there's HFpEF with preserved, but also we also have patients who have sort of cardiomyopathies, and we didn't present the data this time, but showed you the cardiac MRIs of the first 30 patients that we recruit within statin TB. And Solomon, who's I think in the audience, he read the first 100 cardiac MRIs, and I can tell you that only 20% have normal cardiac MRIs, and this is at 6 months of TB treatment. This is their discharge from the TB control program. They have they're labeled as cured. They have a negative culture at 4 months, and what we see is they have pretty normal volumes, so they have a preserved ejection fraction, but they do have late gadolinium enhancement, and late gadolinium enhancement is mid-ventricular. It's often circular, but it's always in the septum area. So this is a feature that you see in patients with inflammation and not with myocardial infarction. Myocardial infarction is always transmural. So we do have an inflammation that is leading to an increased extracellular space where the gadolinium enhancement goes inside, and this is fibrosis. So we probably have patients 5 years down the line after TB who have a cardiomyopathy, have HFpEF kind of picture. So we need to adjust their cardiac risk factors, the traditional ones. I think you've tapped on this. I think this is very important. We need to measure hypertension properly. We need to treat this. We need to look at the hypercholesterolemia. We need to treat this. Everything that is modifiable, maintain the weight is important, and so on. We don't need to talk about traditional risk factors. But what do we need to do with a patient who has shortness of breath and pretty normal lung function, and we think this is a cardiac problem? Does the patient like this need heart failure treatment? And heart failure treatment, it's big for mainstays. You give an ACE on ARB. You don't want to give an ACE of somebody who's coughing already. You need a spironolactone. You need a beta blocker and SGLT2 inhibitor if that is available. This is the mainstay of heart failure treatment. Now, I think this is where the discussion starts. Is this overkill? We don't have really data if this type of heart failure treatment is appropriate in patients, and I would say no. Okay, so then we are actually back to square one. We need to look at the modifiable cardiovascular risk factors and address those ones, right? What does the audience think?
Yeah. Well, let's open it up to the floor for a few minutes. Does anybody want to comment on this, on what we should be doing?
Okay, I find it odd when we're talking of cardiovascular risk and more atherosclerosis, and I worked in South Africa all my life, And I've hardly seen MIs like this. I haven't seen strokes post TB, and neither MIs and things of that sort. And we live in a country filled with TB, so we should be, I would think, seeing a lot more. The issue of myocarditis and poor systolic function, there may be other reasons, and that may be an issue. So, from my side, I wouldn't be giving them statins or aspirin as primary prophylaxis. I can't see it.
So my question is, we obviously see a lot of strokes and heart attacks in South Africa. Do you routinely ask your patients if they maybe had TB 10 or 15 years ago?
We tend to.
And you're not seeing it, not picking it?
I mean, occasionally we may get people who've had TB.
Okay.
And that's part of it. But not, even though the demographics of TB is different. And in the African population, we would have been seeing a lot more MIs in the past. I did see vasculitides and things of that sort, and whether Takayasu's and giant cell aortitis, and that's a separate issue. That's active TB in the vessels.
That's fantastic. You're welcome. Which one would you like?
It's the red one.
Excellent. Okay, great. Great question. So let's take an extension from that. Frederick, do you want to rebut that? And at the same time, do you think that TB could be playing a role in these idiopathic cardiomyopathies that we sometimes see in Africa? And then, Graham, I see your hand up. Let's just wait for the rebuttal, and maybe we can...
Yes, so look, I mean, we have a high incidence of cardiomyopathies. This has been described, and it's multifactorial. We have HIV, we have TB, but we have other reasons for cardiomyopathies. So this is increased in South Africa. Graham?
Graham?
Yeah, thanks, Graham Ankers. Just a kind of contrary perspective, a similar thing is happening in the HIV field where there's a huge amount of biomarker research, imaging research, talking to increased cardiovascular risk, and yet the endpoint research isn't being done. And I think if you had to say what needs to be done, it's the endpoint research to see that there's actually heart failure admissions, heart failure diagnoses, deaths due to heart failure, strokes, increase in strokes post-TB, increase in myocardial infarctions, etc. Because until you document, as we heard this morning, the epidemiology of it, detecting the early events, these might be transient phenomena related to inflammation that resolve. They might remain subclinical. In order to drive health policy, spending on healthcare, you need the endpoint data, and that's what I would encourage the field to do. Is to, there's for instance, in the Western Cape, there's a fantastic data center with the majority of the population are registered on that are accessing public health care. You could link TB diagnoses and previous TB diagnoses to endpoints. But there was a recent study from Uganda published looking at cardiovascular disease in Uganda. Everybody said we would see an epidemic of atherosclerosis in Africa due to HIV. Clearly shows that that's not the case. So just to really make the argument for doing further research before jumping to conclusions. And it should be based on endpoints rather than these intermediate outcomes.
Matt, do you want to pick that up? Because Matt, this is the work that Matt did in the US. Do you want to pick up that thread?
Yeah, Graham, I'm not sure if you saw my presentation this morning, but all of those are endpoints in that post-TB study, and we see the threefold increase in participants with TB compared to matched controls, and those are endpoints based on ICD-9 codes. So,
which setting?
In the U.S. and the UK, yeah, right.
What I'm saying is that in Africa you have a much lower incidence of atherosclerotic cardiovascular disease, far, far lower.
Yeah.
And this is what the Uganda study showed, is that if you go to a community where you have very low incidence of atherosclerosis, then even if you get a twofold increase, it's a tiny increase in absolute terms. Whereas, in Africa, the prevalent cardiovascular disease, as Frederick says, is more muscle disease and HFpEF. And the question is, what's happening with that and TB?
Great. So I'm going to move the Frederick, you wanted to make
just one comment. I mean, there is the Heart of Soweto study where Karen Sleever was the PI, and that also examined 5,300 patients who present with acute heart failure to Soweto emergency care, And coronary artery disease is just extremely rare. We talk about this is not even 1%. And we did a sub-analysis of those ones who were HIV infected, about 500 patients. And there the coronary artery disease prevalence in those ones presenting with heart failure was 2.7%. So it's just very, very low. We have a muscle problem. And I just want to just go back, what do we need to do with those patients? And we just need to thoroughly assess those patients. We do a clinical exam, we need to do an ECG, and if you think, if you have fibrosis in your heart muscle and the patient has AF, then the management is clear. Okay, but I don't think we should act on this. And the data that comes from the statin TB trial, this is at the end when they stop TB treatment. We will do the 1 year and the 2 year study, and we don't know if these findings are transient, if the heart muscle is improving. So I think we're all in agreement that we don't throw heart failure therapy against those patients. Okay, thanks.
So let's pick up another thread. That HIV, TB overlap. TB, HIV obviously are good bedfellows. HIV we think is associated with cardiovascular risk. You're saying TB is associated with cardiovascular risk. So Moises, do you want to talk to that? How are we going to disentangle this?
Yeah, that's a great question. I think it's hard to disentangle the association and confounding relationship when you have HIV, TB, other factors, and then you have cardiovascular disease as events as a main outcome. And then you have to add the regional differences, which is kind of what we were just talking about on the previous question. If you're here in Africa, there are studies like the Uganda study that was just published where you go anyone 40 years or older, the prevalence is very low, 7% or so of subclinical coronary artery disease. You go to North America, Europe, those rates are much higher, 30%, 40%. We're doing some work in South America, and the rates are closer to what will be in the US. But you can see regional differences for sure. So that's one thing. I think that in terms of how we could look at this is having studies where there are adequate controls, and this has been highlighted by Matt and others this morning in the EPI presentations, being able to have very well characterized populations with and without TB and with and without HIV, and then having those validated outcomes, ideally, endpoints, clinical endpoints. Now, those are huge studies, and then when you talk about HIV is not the same, right? You have people who are diagnosed with TB when they are being newly diagnosed with HIV, and they are, they have a high viral load, high level of inflammation, and then you have your other group of patients living with HIV who are more on suppressive antiretroviral therapy, and you have the potential effects of antiretroviral therapy. But anyway, so I think large, very well-designed epidemiologic studies are needed to disentangle the association between TB, HIV, and cardiovascular disease. Definitely the signal is there, especially in the non-HIV studies, kind of what Matt McGee was presenting this morning, and most of the body of the literature has been in the general population. But no, there are no specific studies that have really looked at TB, HIV, and cardiovascular disease. There is more and more recognition that co-infections have a very important role in driving the cardiovascular risk. And one of those, there is CMV and others, but one of those co-infections could be tuberculosis. But I think that still needs to be determined. So I will start with that and see what others have to comment.
Okay. Any comments from the floor?
Thank you very much, and thank you to all the speakers. Really nice session correlating the cytokine storm and cardiovascular disease. I would like to ask a question directed to Didaro, if his study showing DNA methylation, how they apply in the context of cardiovascular disease as post-TB lung impairment. Yep.
This is going to be short.
Just an addition. I mean, if the way you analyze and describe this DNA methylation, is there any area of intervention that could revert that?
This is a very short answer. We have no data. So we have the data demonstrating that DNA methylation correlates and is associated with inflammation, but not the hard outcomes. So the cohort that we are following, we're going to try and follow 300 individuals for 36 months to generate that information. But that's what's been said here is we need those hard outcomes. It is in a population that is 46% people living with HIV, but last time I looked, 92% of them obtained an undetectable viral load before the end of TB therapy. So we'll have to see how that changes. And then I think the second part of that question is what biomarker is best. And I don't know. I mean, there was the recent clinical trial on statins among people living with HIV that identified that statins were beneficial in people without known risk factors or without biomarkers that would normally say that they needed a statin. I suspect we're going to have something similar, that there's some typical biomarkers that already exist in the cardiovascular field and some that are specific to TB, but I think it's this community that has to answer those questions in the coming years. Maybe, yeah.
So with regards to a biomarker linked to statin therapy, it's apolipoprotein B. And with apolipoprotein B, it's one of those biomarkers that aren't your conventional biomarkers that are linked to cardiovascular disease, in the sense that all the evidence that supports the usage of this particular biomarker lends itself more towards lipid accumulation. So with statins, you can understand why it's used, but sometimes you find that with all the cascades and with all the information we have on the biomarkers present, there are certain biomarkers that we could target to answer other questions. So we just have to take a step back and be very careful about going at it with regards to the biomarkers and trying to identify every single biomarker that is known to mankind, because some of these biomarkers do actually play a better role in certain populations than others, and they can then tell more of a holistic story when it comes to TB or cardiovascular disease.
Great answer. I'd just like to point out there are only 3 little prizes left, so get your questions in quick. There was a question at the back first. Are you good?
Yeah, no, I
can. Oh, all right, okay.
I've got a question and a comment. My question's mainly to Vernice, if you don't mind. The inflammation that you describe, sort of vascular inflammation rather than atherosclerosis that you're describing, is that similar in pulmonary tuberculosis as it would be, for example, in lymph node TB? Is there a difference in what you're seeing between pulmonary and extrapulmonary TB? And my comment is, in the future, are we looking towards actually quite extensive counselling of our patients, which I have to be honest, we're not doing now in all of these post-TB side effects, whether it be cardiovascular or respiratory or heart failure? I think we've probably got a duty of care in the future, haven't we, to start counselling patients, which I have to put my hand up, we're not doing to that extent at the moment.
Thank you for that question. It's actually a much needed question that's raised at this particular event. So with the inflammatory cytokines, generally the cascade it's similar. The extent of activation of this cascade would most likely differ. If it is post-TB or even TB, let's put it that way, if it's as a result of TB, the extent of activation would be much higher. Obviously, if you were to see someone who has cardiovascular disease, depending on how many traditional risk factors they present with, that would also then determine how much activation they have of your I want to say cytokine storm, because it's the traditional interleukins that kick in and your immunological as well as your inflammatory cytokines. So with regards to the inflammasome, which is something that I stumbled upon with all the reading. I was pleasantly surprised at how much the inflammasome cascade overlaps with your cardiovascular cascades. And one particular biomarker that I thought was very interesting was endothelin-1. So endothelin-1 tells you about what happens with endothelial dysfunction at the level of the lung, but also at the level of the blood vessels in the body. So with regards to my comment earlier, when we look at these cascades, we need not be blindsided by the fact that we're dealing with a disease in isolation. Because in most instances, the biomarkers that we wish to investigate and identify, they probably do have a dual role across the diseases. When we think of, I'm going to throw this one out because it was a striking comment that was raised by one of the audience members, but coronary artery disease, for example, in certain populations you'll have it more than others. Does that mean everywhere around the world we should be focusing solely on biomarkers linked to CAD? No, it doesn't. So we need to be a little bit more specific and more in tune to the offerings of the environment and the geographical location. I mean, epigenetics comes into play. We have different approaches of counseling our patients. So it's not a one-shoe-fits-all when it does come to the inflammatory cascade itself, the inflammasomes. Anytime we investigate biomarkers, we need to be very mindful about how we approach them.
Ismail Kala had his hand up.
Hi, thanks. So I agree completely with what Graham said, and I think we need to be much more deliberate about our investigations. What we're doing at the moment is we are sampling a whole of indirect markers, hoping to try and find something that's associated. And all of these indirect markers are in every disease process, even in Th2, in asthma. With my PhD, I did the same stuff. And I mean, you're not going to find anything specific if we're looking at diseases as discordant as asthma and coronary artery disease. So we need to be much more deliberate about what we're looking for. And if we're looking for coronary artery disease and we're looking for cardiac pathology, then I think we need to start imaging and looking at, vascular supply. We need to look at maybe, PET scans, SPECT scans, and something much more directed at the organ that we're trying to assess. That's the first point I want to make. The second point I want to make is that with our CT scans, in patients who've got overt coronary artery disease like the one you described, we'll see some coronary calcification. And we're not seeing that. So how are we inferring that the pathology is now vascular? I mean, I can understand that maybe we're not doing specifically directed coronary artery calcification scores, but we're still not seeing, in the vast majority of our patients, any significant calcification within the coronary arteries on simple CT scanning. So that's something that we need to look at. And then the third point is that we need to acknowledge that the disease of TB that we've seen in the Western Cape is completely different to the disease that we see in Gauteng. And Ibrahim will attest to that. The disease, and within the Western Cape, the disease that UCT sees from the disease that Stellenbosch sees is completely different as well. I would even pertain that to that extent. So I think we need to understand that there are heteropopulations of different TB and HIV, and not just HIV, but even if we divorce HIV of TB within South Africa itself. And we cannot extrapolate, one microenvironment and pertain that it's representing the whole of South Africa. So I think we need to be cognizant of those particular aspects. Thank you.
Would you like to comment?
Anybody? I'll just like to add, I really like those comments, and I think in a way it resembles the discussions in the PTLD side where you have different phenotypes and endotypes, and the way how cardiovascular events, disease, risk happens in TB and post-TB, I think has different flavors as well. And identifying those different flavors that are also confounded or driven by regional differences that may go even more to the, if we talk, you were talking about even within South Africa, how presentations will be different depending on where the patient is located at. So recognizing that heterogeneity and also trying to have that call for action and trying to get our cardiology community involved, I think is going to help us understand better some of these different presentations of cardiovascular disease that it seems very clearly from other fields that here, for example, as a whole in Africa, non-ischemic cardiomyopathy may be a major driver rather than the traditional atherosclerotic ischemic cardiomyopathy that happens in some other areas. Yeah.
Hi. Yeah, thank you for a great session of talks. As a neurologist, I've learned a lot. But I just wanted to make a comment, really, which is a lot of what we're hearing about today really also applies to the brain. So the inflammasome activation, the lipid dysfunction with protecting, all of this has been described in the pathogenesis of tuberculous meningitis as well. So you made a call for action to collaborate widely with other stakeholders and to have cardiologists represented. And I think we should also be thinking about other blood vessels within the body, particularly the brain. And I think we could learn a lot from each other and probably improve the efficiency of the research we're doing within this particular field, within post-TB, if we joined up our working and looked at a neurological ischemia as well.
I think it's a great comment. And for that, you get the giraffe. Rodney, you had your hand up?
So we've got the view from the lab and biology, but we're also hearing the discordant argument for local epidemiology. So I just wanted to think about one of the most heavily tuberculosis-affected groups in the world, which is the population of miners in southern Africa that I've sort of been assessing for a long time. There are really only 3 diseases that come up again and again and again. One is tuberculosis, which they've had. The other is HIV, which they've got. And the third is hypertension. On the X-ray, it's very unusual to see cardiomegaly, and it's usually left ventricular, suggesting that that's hypertensive. So I didn't get a sense, I may have forgotten it was presented, where hypertension, systemic hypertension features in the likely or possible impacts of TB or current TB, perhaps in interaction.
Venice, do you want to pick that up? Or Andrew?
No, I'm hoping somebody notices.
Hey. What is this?
Anybody else know?
The hypertension. Hypertension, where does hypertension affect? Obviously, hypertension is a cardiovascular risk and it's on its own. And Rodney was saying that in minors they get 3 things: silicosis, TB, and hypertension. And so, how does that interplay with? How does that feed into your paradigm? And how does that hypertension as a risk, as an outcome of tuberculosis? How does that outplay? Is that the working through rather than the coronary artery itself, but actually hypertension?
From South Africa, Mozambique, and Lesotho. So we don't have to even bring the silicosis into it. I mean, it might be a modifying factor. So really, it could be the interaction of local epidemiology. I don't know how much work there is on hypertension in rural populations. Could be a baseline, but it could be an effect. It'd be unusual to see in miners who've had very active careers, sort of strenuous.
I mean, I don't know what's the data on hypertension in TB and post-TB. I don't think there is a lot, but my hypothesis will be that hypertension, especially uncontrolled hypertension or unrecognized hypertension, is probably a major driver of the cardiovascular disease that we see and then leading to heart failure down the road. And I think that I don't know if Matt, you would like to comment on some of the findings in terms of hypertension incidence in your patients with TB. And I think there is a comment over there from Greg as well.
Greg's. Can you give Greg a mic? Where's the? Oh, sorry. You want to?
No, I think this discussion is really useful because I think, like Graham said and others have said, I think the studies need to be done to look at the outcomes. When you look at like the global burden of disease studies and systematic reviews, one thing to emphasize is there's very little data on heart outcomes. There's very little data about what types of cardiovascular disease are occurring. But the data that are out there suggests that hypertension and stroke are two of the types of cardiovascular disease that appear to be common in sub-Saharan Africa. The other thing about cardiovascular disease in sub-Saharan Africa appears to be it occurs at a younger age. One of the youngest median ages for cardiovascular disease onset in the world. So I think the epidemiology is going to be different. It's probably not going to be atherosclerosis, but also things are changing. So, as there's more urbanization, maybe, at least people have hypothesized that it's going to become more atherosclerotic. But studies need to be done. I would say TB with inflammasome activation and arterial aging, one of the things that would be studyable, and to your point, Bernice, about measuring blood pressure well, would be hypertension. So, but more studies need to be done, and we need to sort out the types of cardiovascular disease.
Great. Thanks very much. It's a lovely comment, Greg. Unfortunately, you only get a marshmallow egg for your comment. Gunnar had the mic, so I don't want to steal his thunder.
Can I just to touch on what was saying, there are quite a few studies in the African context that have looked at hypertension as a standalone without HIV and TB. So just going back to the comment about the silicosis minors, with your Black African cohort, and I mean these are people of African ancestry, you find that there is an increased prevalence. They are predisposed to getting hypertension. So as a result of physiological and anatomical adaptation of their kidneys, they have a different type of hypertension. I'm not too familiar with the interplay of your hypertension that presents in the Black cohort compared to, or rather with, HIV and TB. But just as a standalone, when we look at different geographics, there is evidence to support that within the African context, you do have more individuals, Black individuals, who present with hypertension. And as Greg had mentioned, they present with hypertension at a much younger age. Linking it to Moises' comment about there is the prevalence or the incidence of hypertension. Does it ever get to heart failure? In one of the studies that I've been working on, it's called the African Program of Genes in Hypertension. It was, these community participants were recruited from Soweto in Johannesburg. We found that although the cohort presented with diastolic dysfunction as a result of their hypertension, very few of them actually developed heart failure. Again, the questions that we asked, we had never asked these individuals about their HIV status or even their TB, but there is definitely somewhat of an understanding that we need to take into account when it lends itself more to the geographics. Because what happens in Tembisa, for example, is different to what happens in Johannesburg. But solely based on the genetic profiling of Black African individuals, they are predisposed to developing hypertension. So one of the questions that I kept on asking in preliminary analysis with the TB infant study was, what was their hypertension looking like? These individuals were post-TB. They showed to have hypertension, not as high as we were hoping for, or not hoping, but not as high as we were expecting to see, but ultimately, one of the confounding factors that we do need to take into account is the presentation of hypertension within Black Africans.
Gunnar had the microphone, got snatched from everyone.
Thank you. I liked very much your presentation on thromboembolic disease, and I think it's, for my personal single center observation, it's a very important topic. And I'm just wondering really if, for instance, looking at low-hanging fruits, if we have good guidelines on how to do thrombosis prophylaxis in patients with tuberculosis, to which level and how long and so on, if we could prevent a lot of mortality. And I would be happy to have thoughts on that, because my personal observation when I started working in an African hospital and I came in the morning and people were suddenly disappeared because they died. I never had data, but I think many of them died just of thromboembolic complications. So, any thoughts? Something simple.
I mean, from my own experience, when you've got a patient who's admitted in hospital, inpatient with TB, the risk of DVT and PE is so high. We routinely put them on thromboprophylaxis, whatever you happen to be using. But then by extension, your questions was, well, should you be giving, if they haven't got a thrombus, should you actually continue it afterwards? I don't know, there are many physicians in the room, but my experience is that by and large, once you discharge them, you kind of stop the thromboprophylaxis and hope that the mobility will be sufficient. I'm not sure that there is data to support or refute that statement, but certainly we do see a number of people return with DVTs and PEs, etc. Graham, do you want to comment specifically on that before? Okay. Its microphone's coming.
Yeah, Brian, just out of interest, obviously we do use prophylaxis in people with TB admitted to hospital, both in the acute setting and some of the TB hospitals as well. But one thing that arose during COVID was we were seeing DVTs and pulmonary embolus in people with COVID, and made the assumption that routine thromboprophylaxis is going to prevent that, and yet the trials were done, and it showed that it had minimal effect. And there was then quite a lot written about immunothrombosis, and that it does not actually, it's not amenable to the same prophylaxis. And so I think it's just making the assumption that we see DVTs and PEs, and for giving subcutaneous heparin is going to prevent that. We've never done a trial to demonstrate that, and COVID, that assumption was proved wrong in clinical trials. And maybe that we're not actually benefiting patients, and we need other strategies. So I think it really is something, based on Jen's talk, particularly in the acute setting, that needs further study and clinical trials around.
Good comment. Shame. Poor Ant. Yeah, Ant, your hand's been up for a long time.
Thank you. I just had a comment about that. Just I guess it is different between unfractionated heparin and low molecular weight heparin, and I just know that in audits that have been done in many hospitals, like physicians and surgeons typically don't prescribe prophylactic low molecular weight heparin frequently in immobile inpatients. So I think that's just a comment. But I just wanted to make a comment about the hypertension thing earlier, and I just wondered about inviting nephrologists or renal physicians as well as neurologists, because we did in a study that we did in Peru, we were just looking at, on dipstick analysis, glycosuria and proteinuria, and we did see that there was quite a lot that had glycosuria and proteinuria without known diabetes, and we, unfortunately, in that study didn't have the ability to do bloods and creatinine and HbA1c. But I do wonder about the cross pollination with diabetes and hypertension. Obviously, the triangle of those things contributing to cardiovascular disease.
Good comment. Okay, so let's shift gears a little bit. We now know that it's from work and people in this room that there's this entity of early TB. This what was previously latent TB. Now, Rain tells me is now called asymptomatic TB. I've got it right, eh? Asymptomatic TB, yeah. And so Matt, what about if TB is no longer so clearly divided into if there's this asymptomatic period? Would that be included in your post-TB risk? Should we be what are your comments and thoughts on that specifically?
Thanks, Brian. Great question. Yeah, I think, what I've heard a lot about in this conference is focusing on the 155 million TB survivors and the additional 9 or 10 each year that come up, and that's certainly relevant. I guess the reason why I think we should also be thinking about this is because TB infection, obviously, at some stage applies to about 2 billion people. So even if there are extremely small numbers of people or a strong influence of those people who have tested positive for TB infection, even a small relative increase in any sort of cardiovascular outcome would have a huge population level impact. I guess part of the reason why I am willing to consider that is some of the data that is out there does suggest that, and Moises has some data from both Uganda and Peru suggesting an increased risk of cardiovascular events in those people with LTBI compared to not LTBI. again, we know that LTBI is very heterogeneous now, so I don't think that anybody who tests positive for LTBI has that phenomenon, but again, even if there's a small proportion, the potential population impact could be enormous. Another sort of analogy to that is what we looked at in the impact of TB infection on diabetes incidence. So similar to the cohort studies we did looking at incident cardiovascular disease in the VA population, a couple years ago we did a study classifying people based on their LTBI infection status. So we knew if they tested positive or negative for a quantiferon or a TST, and we followed them forward and found an increased risk of diabetes incidence in the VA population. So there's some sort of underlying reason to believe that that type of relationship could hold. And then again, there's other data from Northwestern University in Chicago that demonstrated an increased risk of incident cardiovascular events in people with latent TB infection. So I think there is some precedent to consider that as an important outcome or important relationship.
Anybody else on the floor want to comment on that?
Sorry, and one other thing I would just real quick is just say, I think that again, like a lot of the comments here, this could vary a lot by geographic location and type of infection. And so I'm really happy to hear that because that means I can keep my job. And all of you can too.
Yeah, I think it also depends on the bug, the MTB, different bug. We know there are different strains. I think about 7 strains, lineage strains. We looked at, using spirometry, we looked at cross people of African ancestry, Caucasian ancestry, and we merged with the lineage that comes in with their, where they originally come from. And we found an effect size of about 30%, which was significant. So if we think about how we relate with TB and how as a species we have related with TB over time, there's been a very good sympatric and allopatric relationship that would allow people to get some kind of protection with TB. And sometimes when it gets convenient for TB, it gives you the disease so that it can also have its own children. So I think when we look about the relationship that we have had with TB and the immune response, I think we need to give the bug some kind of respect too.
Right.
Thanks. Yeah, I think just to be pedant a little bit, I think that I appreciate that the number of people, I mean, I'm partly responsible for that 2 billion sounds like a very big number, it's a very big multiplier. But it is important to distinguish between the 3 different things. Like LTBI effectively doesn't exist anymore because WHO says so, they scrubbed it completely. Then there's MTB infection, which is something we can't really detect, and then there's people who are immunoreactive. And within that, there's 2 people, there's 2 sorts, people who have been immunoreactive in the past and are currently immunoreactive. And those are all different groups, and the size of those groups will vary massively, going from potentially having been 2 billion, if you go cumulative, to down to 100 million. That is quite a big differential number. So I think it's really important to, when you think about how much does it affect, and I'm not diminishing 100 million to a lot of people, but that's a very different number. And I think it's important to distinguish and be clear, because what particular phenotype are you describing? Is it people who are at that particular point immunoreactive? That's okay, but it's just important to be precise in that, because that is the multiplier that you're using. And what that means that they were immunoreactive at that point, aside from that, there's an association, which I'm an epidemiologist very happy with. I don't think anybody really knows. If they do, then I'm happy to debate and to check. But just to be clear, what group, what phenotype are you looking at?
Well, it's why somebody needs to solve the problem so that we can directly measure viable MTB instead of indirectly measuring indirect tests. And it's going to be challenging to answer that question until we get over that major technological hurdle.
I have a
Matt, I'm going to
comment
stick with
here.
you for a moment. Something that bothers me is that
No, it's okay.
something that bothers me a little bit is that TB is so associated with poverty, okay, and poor living conditions and all sorts of things that come with poverty. And we heard by the epidemiologist this morning about how important confounders are. So in your work in epidemiology, how convinced are you that you've accounted for all the cofactors of poverty that could be increasing your cardiovascular risk, that it's not just TB, it's just not a biomarker of poverty and those risk factors rather? How convinced are you of that? Because it does bother me.
Yeah, it bothers me too. And unfortunately, I think that nobody knows the answer to that question. And I mean, that is the problem with all observational designs. And I think that's going to not be, but that doesn't mean we can't make causal inference just because it's an observational design. We just can't get over that. There's nothing else to do other than to use better designs and, again, the need for replication, because I think, as we've all said today, it's going to differ by site. In our study that we did in the VA cohort, though, we were able to match on factors that are closely associated with, control for confounding, including SES. We had measures of income, measures of education. We also matched on location and residency, access to clinics. So, as good as you can get almost from an observational design. I would also say, just from my experience, when you have a huge study design or population sample size, the effects will still be there. You can still see a very small relationship, even after controlling for many, many factors. And I think that gives us better inference. But the short answer to your question is, everybody who's an epidemiologist should just quit if we stop relying on observational data, because there's no proof. You can never prove anything 100%. So, yeah.
Matt, I'm not an epidemiologist and I'm horrible here, but in some of I know at least one paper, the Christensen paper that was included in the meta-analysis, their controls were household contacts. How does that change your guess that they're doing the best they can to control poverty?
Yeah, that's a good question. We've thought a lot about whether or not it makes sense to use household contacts or community controls, because there are, and we were talking about this with Blanca earlier today, there's clustering of risk factors within households as well. And then also in contexts that you can't get rid of the potential impact of a recent infection that hasn't yet been diagnosed, for example. So I guess from my perspective, in an ideal world, the community control would be the ideal person to match on. So if somebody has TB and you want to find a control to approximate that counterfactual, it would be somebody in the same geographic residence, like a neighbor, basically, who's matched on everything else except for the...
Yeah, I just wanted to circle back to the hypertension and the concept of variations between observations and study populations. I work with Hispanics on the Texas-Mexico border, and I had communicated with Moises about looking at latent TB infection, realizing whatever that means, latent TB infection, and hypertension, and we just couldn't find an association. So that's another difference.
Okay. There was one. He was there? Okay. Anna? We're running out of Martian. This has been a good session. Okay.
I just wanted to come back to the question that you asked around what the potential implications of asymptomatic TB might be for post-TB. And we obviously need to generate a lot more data to actually determine that. And I think maybe on Jen's slide, you kind of had up on the screen during, I guess, this acute TB stage I think there was acute inflammation that was ascribed to TB, and then in that kind of post-TB phase there was fibrosis and cavitation, etc. But I think what we see in individuals with asymptomatic TB is that they do develop cavities and they have fibrosis prior to symptom onset. And so if we're saying that those things are forms of post-TB, then we see that asymptomatic TB already has the evidence of those post-TB lung disease phenotypes, and they have the chronic inflammation which contributes to the development of cardiovascular disease and other vascular issues. And so I think that when we really tried to bring on the idea around, or trying to emphasise, I guess, asymptomatic TB and subclinical TB as being really important disease states, the outcomes of that we included in that was post-TB, all forms of post-TB, because we need to be able to measure the impact of early treatment of asymptomatic TB on these other outcomes. And I think they are a major contributor to it, and it would be great for people to start considering also looking at asymptomatic TB and not just symptomatic patients when we're trying to look at these outcomes, because disease exists in a pathological sense, as we saw today from Threnessen's talk, that there is extensive disease and damage that happens, and the disease is not just the presence of viable bacilli or the presence of symptoms, it's the dysfunction that happens to the tissues which impacts individual function. And so, yeah.
Fantastic. So, we're getting to the tail end, and I'm going to make the last question about the elephant in the room, is that there are no cardiologists in the room. Okay, as Venice pointed out. And so, Venice, how do we engage our cardiology colleagues? We've talked about the renals, we've heard about the neurologists, but clearly there's a major group that is missing from this discussion. What are your thoughts and comments on this? Just from my, let's hear your comments.
How do we engage them? We invite them. We invite them and we present the data. In a lot of the studies that are currently being conducted on TB cohorts, a lot of researchers say, we're doing cardiovascular measurements. Are you really doing a cardiovascular measurement that would entice the cardiology community to come forward and investigate and answer the questions about the damage that's caused to the heart? One of the presentations that was given earlier highlighted the use of echocardiography to give more information. If a cardiologist uses echocardiography, you give the cardiologist echocardiography to use. That way, it's adding additional information to the information that we don't know about. So beyond the cardiologist, there was a very good comment that was raised about the inclusion of nephrologists. And that's right, because with the nephrologist, there's the neurologist, the cardiologist, so there's a whole lot of stakeholders that we're actually missing out on. We can focus on cardiovascular disease and think we're going to go that route by including just the cardiologist. But even then, the research that needs to be done actually extends beyond us all. We invite them, Brian.
Thank you, guys. Thank you, everybody, for a really great session. I think it's been a really stimulating session. I think, as always, in everything with the symposium, we always end up with 20 times more questions than we have answers. But at least we have momentum. When we have a guideline, we know where to go, we know how to get there. And so that's a wrap for the session. We are coming back at 4:20 in my mind. 4:20. So please enjoy your tea break, and we'll see you at 4:24. Thank you so much to the speakers.